on this computer. Okay, we're in business.
Sounds good. Thank you so much, Professor Alexander, for allowing me to join your class today. My name is Dr. Margaret Nye. I am a psychiatric mental health nurse practitioner. I work with children and adolescents in Vancouver in a wraparound intensive services outpatient program. I have my DNP from Rush University, and I have my BSN is from Linfield, and I have several friends who have graduated from the Fox program. So thanks for having me. Also, as part of my role, both as a PMHNP, and then also as part of my doctoral project, I focused a lot on suicide screening and assessment. My focus has been primarily on adolescents, since that is the area of my clinical practice and population that I really get excited working with. But I have been trained and have administered assessments throughout the lifespan. And so today, I guess our plan is to be able to just kind of have a discussion about suicide risk screening assessments. Why is it important? How do we do them? What happens when there's a gray area? And my intent is to keep it casual. I love any and all questions. I've been using Zoom for telehealth, but I haven't been using it in an academic environment yet. And so, yeah, I was just looking to see, oh yeah, I guess there's that chat function maybe, or Professor Alexander is going to keep us all on track. She's also going to keep me on track if there's things that different things I should talk about, or if somebody's asking a question and I don't notice. So, and I admit it's weird doing this virtually where I can't see you, which is fine. You guys are all fine. You don't need to change whether your camera's on or not, but it's just definitely a different setting. And wow, what a week, everyone. Like, this is some heavy stuff. And now here you all are wrapping up a week talking about some more really heavy stuff. And so I really hope that in the midst of all of this, that you're able to do some things for yourself that can help build your resilience, because this is not normal. This is not okay. I think I saw a meme that said, if you didn't have an anxiety disorder already, one will be assigned to you, just based on what has been going on the last couple of weeks. So really, I want to be mindful of that just as we start talking about this really another heavy topic. So suicide and suicide screening. Regardless of whether you have a passion or an interest of going into mental health nursing, regardless of what setting you end up working in, having the skills to perform a comprehensive suicide assessment is going to be critical, both in your work setting, but also just in your life. I do this all the time at work now, but when I first learned about suicide screenings, I was a nursing student, and I learned about it. We did our mental health rotation in the second semester, and then I had summer break. And over summer break, I got a call from, I used to be a camp counselor at church camp, and I got a call from one of my former campers, and which was kind of strange because I hadn't heard from her in a while, and I was chatting with her, and then something seemed kind of off, and I kind of asked some questions about how she was doing, and she sounded like she wasn't doing so well. And then I asked her, are you thinking of wanting to die, or are you thinking, I don't exactly remember the words I used, but she said yes. And then I said, oh my gosh, in my head, and I pulled out my my textbook from school, because I was on the phone, and I went through the questions with her, and it turned out she had plans to drink alcohol and take benzodiazepines after we got off the phone. And she was right about to go through with that. But I ended up going through that assessment with her. And then I ended up kind of safety planning with her, going to her house and picking her up and taking her to the hospital. And that was 10 years ago, and she's still alive now. And she was able expecting that at all. I was not working in mental health. I was working in retail. And it was one of the most important things that I did that summer. And who knows? I mean, and so I guess another takeaway is with you guys, you've already noticed are more vulnerable with you than they might be with some other different folks. They'll have you, look at the rations, but they also are more likely to be vulnerable with you about mental health. And when they're having thoughts of wanting to die and thinking about suicide, they may be apt to tell you. And what it really comes down to is the importance of asking the question. If you can take away, thinking of killing yourself, or are you thinking of ending your life? That is the most important thing. And it is so hard to get those words out sometimes when you haven't practiced it again and again and again. But nevertheless, it's extremely important. And it's something that could be worthwhile practicing with your peers who are hopefully, I guess regardless of how all of our mental health are right now, but just kind of getting those words out and practicing this again and again, so that in the event that you would need to do this in the future, which will be a when, working in the field, in the field of nursing, you will have had some practice under your belt and really kind of understands the what and the how. So, the background of framing it. But then I just have I get excited about this stuff. Again, my doctoral project was on suicide screening and assessment for kids at a child abuse facility. And so obviously very high risk population, and we did universal screening. And so I did a deep dive because that's what you do in grad school. And so one thing that I think is really just remarkable in Oregon is it's really tough here. The statistics change every year, of course. We have epidemiologists in the state of Oregon that collect data on this. And my statistics are a couple years old because I'm just delightfully done with school for this moment. We'll see. It keeps coming back to me. But so I don't have the 2019 statistics, but in 2016, 2018, we're usually ranked somewhere about number 11 or number 15 for states that have the highest number of suicides in the country. And that is particularly true for adolescents and young adults. Suicide is the second leading cause of death for I think it's ages 15 to 35 in the state of Oregon. And for every single age group, it is in the top 10 causes of death. And so it definitely is an epidemic, and the numbers are rising. And suicide, again, some of the stuff, I will mention adolescents just because that's my area of focus, but there's similar stuff going on in different populations. But for adolescent girls, the rates of attempted suicide have doubled over the last 10 years. And also it's gone dramatically up in males too. And so again, this is something that is more and more important, that we have a good awareness of what we can do to screen, assess, and hopefully provide some intervention. So, oh yeah, and if folks have questions, like I said, I'm down for any questions you might have. So, and I guess the next piece would be to talk for a minute about risk factors. And I guess just to make sure I'm on the same page, Professor Alexander, have you talked yet about this stuff? Like risk factors, protective factors, or is this the first?
This is pretty much the first part because this is only their third week. So far we've focused on, we started out with therapeutic communication, assessment, and then psychopharmacology. And we're actually not going to talk about depression and suicide until later. So I thought it'd be good to have this early rather than late to get that, the duty to warn and all that good stuff. Yeah.
I like it. And like I said, keep me on track if there's stuff that we should be talking about that I am not. So I guess going to risk factors then I won't quiz you all, although it's really hard to do in a Zoom meeting anyway, so there's that. But so risk factors, again, just kind of giving a framework. You can't change them. Risk factors you've got with you. I mean, there's stuff that's happened to you, or where you are in relation to other demographics. Those can be risk factors. factors. So risk factors are going to be, for suicide, include being male. Males, on average, die by suicide at a much higher rate than females do, although females attempt suicide at higher rates than males. So being male, being a sexual minority, if you identify as, if a person identifies as LGBTQIA, then that there's much higher rates of suicide, particularly gender identity. And then also ethnicity, particularly Native American, Hawaiian Pacific Islander, Hispanic, Black. And there are, yeah, and then also if you have experienced abuse in the past, or if the client has, or if socioeconomic disadvantage, and so those types of things, and the list goes on and on for risk factors. There's just many different things, and again, you can't change those. Like that is just kind of your lot. I mean, it just, you have these risk factors. And of course, again, having these risk factors does not mean that this person is going to die by suicide or attempt suicide. It just adds to the likelihood that there could be, that there's a propensity, maybe higher than the general population, which we know from lots of areas of nursing about health disparities and how different groups are disproportionately impacted. And so, aside from risk factors, there are also warning signs for suicide. And warning signs, that's not, I mean, those are things that you can change, or they can change. Like those are like behaviors. So a warning sign would be wanting to give away your belongings, saying goodbye to folks. I had a list, and then now it would be really cool if it would cooperate so I could remember, because it's important. Oh, here we go. Talking about wanting to die, that's a big one. Talking about being a burden to others, increased substance use. That's another one. If they're, drinking more alcohol or using drugs, sleeping too little or too much, displaying extreme mood swings, or being withdrawn from family or friends, or feeling isolated. Again, these are those warning signs. You may or may not know those when you are caring for a patient in whatever setting you are. You might, depending on what kind of information you have, but there's still important things to think about when you're working in long-term care, even, or when you're doing your clinical rotations anywhere. If we're hearing people saying, "I'm such a burden," and then maybe the person is no longer going to activities, or it again can just kind of be some reminders that this is some red flags that we need to check in about this. So on the flip side of warning factors, there are protective factors, which you might imagine is things that can be protective or make it less likely that a person might be thinking of attempting suicide. And for protective factors, again, there's a long list, and they can look lots of different ways, but one of them is, and in fact, one of the most important ones is connectedness to family, to community support. Someone who is well supported by their community is going to be much less likely to attempt suicide than someone who is very disconnected. And that can mean a lot of different things. That can mean, when we look at adolescence, we think communities of faith can be extremely important. Sports teams, scouts or clubs, or something where the teen is feeling that they have a place where they can be safe and they can be heard. And of course, you can imagine that goes the same for adults as well. Also having a sense of purpose or meaning in their life, and problem solving skills, and just the ability to be able to think through conflicts, or just kind of that distress tolerance and emotion regulation. And then also cultural and religious beliefs that discourage suicide. That is a protective factor. So that's a lot of the background about, kind of some stats and risk protective factors, warning signs. Now, I think we'll move into some screening tools. And so, we talked a lot about it. And then, I've been saying how important it is to ask people. And then probably want to have some framework for how to do that, because it can get kind of tricky. But again, with practice, we all start at the beginning, and then it does get easier over time. There are a lot of different tools out there to screen for suicide. I only want to talk about 2 of them, and I will send, if Professor Alexander does not already have them easily, I will send them to her very easily, so that you can access them and kind of just take a look if that is what you choose to do or what you're assigned to do, either way. And so I'll talk first about my very favorite tool, because it's for adolescents, and then I'll talk about one that's used all over the place as well. The one that I use for my project and the one that I use in my clinical practice all the time is called the ASK tool. It stands for Ask Suicide Screening Questions, and it is my favorite tool because it is has been designed to use for adolescents. There's some idea that it might eventually get approved for adults as well, which would be awesome. And it's only 4 or 5 questions. And the questions go quick, and it takes like 20 seconds or less to administer. And the psychometric properties are really good. So it's valid. It doesn't have not very many false negatives or false positives. Like it works. And that it's available, it's public domain. It's available on the National Institute for Mental Health website. And it comes with both the screening tool and then also an assessment tool. So again, and I imagine you guys know this, but a screening is something that everybody can get. Like you go and get a blood pressure screening when you go see primary care, even if maybe you're there to get a flu shot. Like it's not because they think you have a problem with your blood pressure. It's just a screening. Or as we know now, temperature screenings everywhere we go. And then an assessment would be, if something was awry with the screening, then you go into a deeper dive. And so if somebody passes the screening, then you just kind of move on with your life. But if, your blood pressure comes back and it's sky high, there's going to be some follow-up and a further assessment. Like, are you actually in a hypertensive crisis, or was the cuff on wrong? And so that's how the tool, the one that's the best one for adolescents, I think, this ASK tool does. They have just the 4 screening questions and then go deeper into the assessment. And so the questions too, these are good questions regardless. Like they're easy to memorize. Is the first one is, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that your friends or family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? And then have you ever tried to kill yourself? Oh, that's it. And then if somebody answers yes to those questions, any of those, you ask one more, which is, are you having thoughts of killing yourself right now? And so if they say yes to that one, then you want to escalate things, and we'll go into that in a minute. But if they say no, then there's still an assessment that you can do. So again, I don't need to get too far in the weeds with that, but I just want you to know that there are different tools for different populations, and you're going to find out, like in your clinical practice site or whatever it is that you do, you will get familiar with a tool. And if you don't work with kids, it might not be that one, but it is still my favorite for its ease of use. It's real quick, and it's less clunky. However, the one that you guys will probably all be using in clinicals, because it is kind of the gold standard, is what does it stand for? The Columbia Suicide, this is terrible. It's the CSSRS. Here we go. Columbia Suicide Severity Rating Scale. That was bad. And it's the tool that is embedded in most of the electronic health records in our area. If you go to any of the behavioral health hospitals, I'm pretty sure it's what they're all using. Again, I'm a couple of years out.
You worked at Unity, didn't you?
I did work at Unity.
So we have students at Unity and at OSH, and I'm pretty sure they still use it. They used that at Unity, right? That scale.
I think they do.
Yeah, I believe so. Okay.
When I worked there, yeah, I worked on the 6th floor of Unity with kids. Kids, surprise! And when I worked there, I worked there right when it opened, and so there was some stuff that was still kind of being rolled out. And when I left, I was there. I was in the predecessor to Unity, and we all moved over. And I was there for about 6 months. And when I believe I remember when I was leaving. That's when they were starting to kind of roll that out. And so, so I didn't have any firsthand experience with it there, but yeah, I think anywhere you go right now. And so the CSSRS is also a great tool. I wasn't meaning to hate on it. And their website has tons of different screening and assessment tools that you can use. And they're all the same CSSRS, but what they have is they've made it for different people. So you can have it for if you're working in corrections, or you can do as screener when you've seen them within the past month, or you can do it, you can download a little card that you can put in your wallet that you can use out in the community. And that's actually pretty cool. Like you can just, have it on you, or even screenshot it with your phone and save it, so that if you're in that situation with my camper or whatever, where you're not expecting it and suddenly you're like, oh my goodness, I've got to do this assessment, it's very easy to access. It embeds the assessment in with the screening. And so like that last tool that I was talking about where they're very separate, the Columbia is much more, you know, if you answer yes to this question, then you have to ask this one and this one and this one. And so in an electronic health record setting, or in a setting where you've got your computer right there, which is a lot for nursing, it's very handy. It can get just a little bit more confusing, I feel like, if you're all out on your own, but that's where those pocket cards come in. And I think that really having a familiarity with the CSSRS is a good thing to have, even more than my favorite tool. Yeah, and I don't know. So I guess Professor Alexander, you will probably have the CSSRS for them to look at.
The main thing, like in our textbooks, we did talk about this briefly for assessment. It's mostly like the really basic questions of positive or negative suicidality, and then going down the steps towards lethality. Yeah.
Mm-hmm. Yeah. Okay. No, that makes sense. And actually, that is a good segue to. So let's say that you are talking with someone. Let's say they're your patient. That would probably be a good way to frame it. And let's say that you're going through these assessments and you found out that they're not, well, I guess there's a couple different things. If they said no to everything, then that's probably all you can do. If you have a gut feeling that there might be some more going on, I mean, that's when you might want to, I don't know, talk to your supervisor or the staff, or just say, I don't know the answer to all my questions, but something seems off. Like I think it would always be good to collaborate whenever you have something tricky. And then let's say that they answer, yes, I am wanting to die. I sort of have a plan. I don't know, and that's when you really want to start going into more of a deep assessment and figure out, like, is this person safe to leave the room or not? And it's easy when people say no to everything. And then it also becomes easier when people say, here's my plan. This is what I'm going to do. And I really mean it. The reason I say that's easier is because it's very simple clinical decision-making, which is this person needs to go to the ED and be evaluated. They're not safe. They cannot leave. We need to escalate things. And so in that sort of situation, if you have someone like my camper who is saying, by the way, this is what I'm going to do next, although ideally they're not on the phone, they're like your patient, then you do not want to leave them alone. That is one of the most important pieces. Let's say that you're in their room with them and they're saying, yes, I am very suicidal. I have a plan. I have access to this plan. The plan is lethal. and I have an intent to go through with it, you need to call for help with your eyes still on them. You don't leave the room, go looking down the hall for someone. You need to find a way that you don't leave them and you get some more people to help. That's another really, really huge takeaway. And then for the folks who are in that more of a gray area where you're not really sure, then you are going to want to do a pretty thorough assessment. The CSSRS, the Columbia one that I was telling you about, it does a pretty good job of asking the basic questions for an assessment. But if you don't have that right in front of you, it would be a good thing to just kind of know the basics about what that would be. And so the first piece of it is to start by praising the patient, by saying, this is really hard to talk about, and I'm really glad that you trusted me enough to talk about this tough stuff. I thank you for telling me, and I'd like to ask you some more questions. So really start by that centering and attuning, and it's just, it's being like showing your humanity too. This is tough stuff, and if someone is saying to you that they want to end their lives, like we want to, respect that that vulnerability as well, and really take that seriously. So we always start with saying, thank you for telling me this is, I want to help and ask some more questions. So then we'll want to find out, like, how often are they having these thoughts? It's very different if you're having like thought once a week versus all day, every day. We want to find out what their plan is. And one of the things that I sometimes ask, so I work with teens, like I've said many times, and a lot of times I will be doing this. And the teens that I work with are very high risk for suicide. I work with it's very high acuity. And so it's quite common that the teens that I work with do think about suicide, do have many attempts in their past, lots of risk factors, lots of warning signs. And so I'll ask them, what is your plan? Or can we talk about what the plan would be? And then they'll be like, oh, I don't have one. And I wonder, I can respect what people tell me, but sometimes it's like, all right, I've been around the block. I know you have one. And so sometimes I will rephrase it and I'll say, oh, okay, well, if you did have a plan, what would it be? And you would be surprised how many times that the plan comes out when you kind of, take the pressure off and be like, just hypothetically. And then many times when I've done this, it turns out it's actually quite detailed. And then of course, sometimes I'll get like, I literally just told you I don't have a plan. And then, you can move on. You also want to find out what kind of social supports they might have. Who are people that they can reach out to? Do they have a therapist? Do they have a mental health provider? Do they have family that can be a good member of their team? Do they have friends? Do they have, any of those protective factors? And also maybe looking through some of the risk factors or warning signs. You may not have time to do all of this when you're meeting with a patient, but we're talking ideal situation right here. And you'll also want to find out what other sorts of symptoms they might have. Like, are they also experiencing a lot of depression? A lot of times people are experiencing depression when they are thinking of ending their life, but there's also a lot of times when they're not depressed. And that's interesting and also can be deadly. And because people don't expect it the same way. It's like, well, they weren't even depressed. Plan. Also finding out, have they ever tried to hurt themselves in the past? Or have they ever tried to kill themselves in the past? That's another important risk factor that we look at when we're talking about. And then you also want to ask, a really important one is, what are some of your reasons for living? That can often frame it. If they say, oh, I have gone down this path a lot before. Well, I'll have a teen who I'm starting to feel pretty worried about because they're saying yes to all this stuff. And then I'll ask about the reasons for living. And then they'll just be like, oh, but I could never do it because of this and 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 this. And they're earnest about it. I mean, obviously we're still worried. That's par for the course, just worrying. But it did make me feel less like we need to drag them straight away to the hospital. So then after all that, and again, it doesn't, I don't know, I feel like I'm also, this is all important stuff. And I think at the end of this, we can just kind of have some big takeaways too, because it's okay to be meeting with a patient, to be asking these questions and not going into every little thing that I just said. There's lots of different ways to do this. And even just asking the question and communicating with your team is really the most important takeaway. If you don't have it memorized about, oh, which risk factors do they have and which, you're still providing good care. Obviously, the more you learn, the better. But this is also something that people should be able to access at their comfort level. And the most important part is asking that question. So you've assessed and you've decided that, well, this person's probably not going to leave my office or leave this facility and kill themselves, but it's still a risk. There's still, we're not ready to send them to the ER. We could probably send them home, but there's still just kind of that level of worry and they still are wanting to die. And so that's where safety planning comes in. There is a really good template that is all over the internet. I will also send this to Professor Alexander, although I imagine that she has it. It is by Brown and Stanley, the safety plan. It is, Zoom is not great. It's okay. I not want to share my screen. But it has, it's like this paper with a list of steps that you can do for safety planning. And you do this with the client. Safety planning, by the way, is different than contracting for safety. Some people who have worked in mental health or maybe have lived experience or know people who have experience, there used to be a more prominent thing about, they call it contract for safety, where you go to, I don't know, some healthcare environment, maybe you're in the hospital because you're feeling suicidal, or maybe you're in primary care, and they'll say, let's sign a contract that you won't kill yourself. And those are not evidence-based. It makes the provider feel better, but that's not what this is about at all. It doesn't do anything to reduce suicide risk by saying, please sign here that you won't. It's not. People will do it because because of maybe that white coat syndrome or just wanting to get out of the emergency department, but it doesn't work. What does have clinical evidence though is safety planning. So not contracting for safety, but planning for safety. And that again is done with the client, patient. There's a lot of different words, especially in mental health. We say clients, sometimes we say patients, sometimes we say consumers. I've been trained with different organizations that have real strong feelings about one word or the other. So I've been bouncing around a lot, but really, the person who is receiving care, you work with them to figure out what are their warning signs. Ideally, the client would write this themselves on the paper. Warning signs that a crisis may be developing. What are their own coping strategies? Things they can do to take their mind off their problems. So, that'll be unique to them. Maybe it's like artwork or calling a friend or, going on a run or whatever. And then people and settings that can provide distraction. And then this one, they write their names and then also a space for their phone numbers in there too, which is becoming a little less relevant now that everybody has smartphones, because we don't know phone numbers. But I mean, but it's still good to just have that there. And then people for whom I can ask for help, having a list there. And then professionals or agencies I can contact during a crisis. This is where, and as part of the safety plan, you can write, if they have a therapist, great, you can write down their info. You could also write down, there's like urgent care or the suicide prevention lifeline phone is on the safety plan sheet. And so just kind of, any resources that might be specific for the patient that they could access. And then finally, they also say, then you do making the environment safe. Like, so this might look like, I give all the pills to someone else, I don't have access to administer them, or I will get the sharps out of my home, or I won't be, I don't know, that again will be really individual for the person. And it is definitely an important step. And then finally, it's the one thing that is most important to me and worth living for is, and then they can determine that for themselves. And so with that safety plan, the idea again is that the person, when they are feeling in crisis, they can access this as a resource. And they can, look at this sheet and they can be reminded, oh, shoot, I've got these warning signs right now. Or, and then they can see on the paper, here are things that work for me when I'm feeling overwhelmed. And this is good for all of us. We should all have a safety plan right now. I mean, this is like, and I'm serious, like it's tough out there. And it's been overwhelming. And I remember being a BSN student, it is overwhelming at best of times and very difficult at best of times. And then now adding, global pandemic and the state's on fire and all the other things that are going on. This would be a very reasonable thing to do as an exercise for your own self, even. There's also a lot of other resources out there too. There's this thing called hope boxes, where you can create a box of things that are meaningful. So it's sometimes like a picture of someone that you love. Sometimes it's something nice to smell. Sometimes it's like a note to yourself. There's lots of different cool stuff out there online that again is evidence-based and is can provide it can provide hope. And it's something that, if you're aware of that stuff and if you're having an opportunity to sit and work with a client on safety planning, these could be resources that maybe you'd want to share with them. So finally, I guess I was saying all along about how important it is to ask the question, but I think that there's one of the hardest parts again, and I did kind of allude to this earlier, is what are the words that we use and what is the segue? And that is obviously, it'll be different depending on who you talk to and dependent on the setting. But one thing that I kind of just fall back on when I'm just not really sure how to start, it's usually I'm talking to someone and I can tell they're quite depressed or they're just really not doing well. And what I'll say is, sometimes when people have felt bad for a really long time or have gone through the things that you're describing, sometimes they have thoughts about wanting to die or wanting to end their life. Is that the case for you? Is that something that you experience or something like that? And that kind of takes, it kind of generalizes it. And it makes it kind of a gentler foray. And that's a lot of times is for our benefit too. Like if we're feeling worried about asking the question. And then sometimes I'll say, this is really tough stuff. And, sometimes people have these thoughts and these are things that I do ask regularly of a lot of people. It's something that's important to ask. And so just kind of even, normalizing it and making it part of your assessment can also be helpful. The evidence shows that asking someone if they want to die, asking someone if they're suicidal does not lead them to make an attempt, does not put the idea in their head. On the contrary, it can really help save a life. When people, often if they are asked directly, then they will respond in earnest. And if they're asked in kind of a sideways way, like, well, are you feeling, I don't know, then they might not answer honestly. So asking directly and following up, asking again, saying it's, that this is an important question is the most important part. So we covered some statistics, we did risk factors, warning signs, protective factors, talked about some tools, talked about the assessment, talked about safety planning. Professor Alexander, what am I missing? There's always more.
This was great so far. Do you have a couple things. I know that it feels really awkward, like you were saying at first, like that's why we want to use like a euphemism or we want to be a little bit more indirect. And I think, do you just have any, I do think it gets easier the more that you do it, but it's still just a hard thing to ask. Like, do you have any like tips for how to get over that feeling and how it was for you, I guess?
I didn't get over it until I had probably done it maybe 300 times. And which is maybe, but should we though? I mean, like this is one of the, like, it is so scary. And suicide is so prevalent. And, you know, and then it's also both the, like, will I say the right thing? Did I ask the right questions? Will they be offended that I did? Should I have even gone there? I'm escalating things, you know, and I would actually think that it is good to have that worry, because I mean, the opposite is then, I mean, you can go into this field and you could do it 6 times a day, every day. And then, you know, eventually then that becomes more routine. But until you're having that level of practice, it is going to be scary. And I think it is going to be just kind of honing into your resilience skills. I know that what I used to do, and I still will sometimes, I still get scared sometimes, especially when folks are answering like, yes, 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 yes. I had a kid just not that long ago and we're doing telehealth. And they needed to go to the hospital, but they're not in my office. They're in their home while I'm in my home. And that was pretty nerve-wracking, because I had to make sure that we could trust the mom to take the kid to the emergency department. The mom's fine, but it just, I mean, it is still scary. And so I think, again, like, you know, just digging into the reserves of like, what do we do to make us feel strong and resilient? And I've been getting really excited and into the community resiliency model recently, because if I'm spending all my time on suicide, I have to have something that grounds me too and gives me hope. And that is a whole, I won't go down that rabbit hole today, but that's a whole nother thing, where there's these easy exercises for your own resiliency, and easy exercises for resiliency of our clients and our community too. And so sometimes I will do those, like I'll ground myself. There's many different ways you can do that. And I will remind myself why I'm asking this. I will remind myself my professional duty, my moral responsibility. And then, you know, you just jump off that deep end. Like, I'm sure all of you in nursing school have been in that situation many, many times when you're like, I am so scared. And here I go. You know, with that definition of bravery is not that you're not scared, but it's that you're scared and you do it anyway.
Thank you. And then something that I thought that was really cool that you said that I try to follow as well is instead of saying commit suicide, died by suicide or completed suicide. It might not seem like a big change, but can you kind of explain the reasoning behind that?
Thanks for bringing that up. I was meaning to do that and then I got sidetracked.
A lot of good stuff to say.
There was a lot. But yeah, I mean, that is a really important distinction. Saying someone's committing suicide, that's a crime. I guess, I mean, technically suicide, I think, actually still is a crime some places, but we're not working with, this is not a criminal thing. This is someone who is feeling so vulnerable and so at the end of their rope and so bad that they're wanting to die, and adding this like criminal to it really just further stigmatizes, and it doesn't make people want to discuss these thoughts if we're just calling them criminal. And so it is using really direct language about, died by suicide. Or even, I did say attempted suicide a couple times, and I should stop. You should say, trying to end their life, or, because if you attempted it, then you failed, right? Like that's not a good, like I don't know. So language is tricky. Language is evolving. Language is important. And then actually, even now, died by suicide comes out on top, even over completed suicide. Because if you complete suicide, then it's like you completed the task. Like so there's again, language is going to be ever evolving. And I think, again, centering our intentions and then centering the client's needs and is our the best way I think we can go about it. But yeah, we do stay away from committing suicide.
And I think that's a relatively new change in language, at least for me.
It is. It is.
And then this is a hard question. I didn't warn you for this one.
Right.
But sometimes, no matter what we do, people are going to make that choice. And if you feel comfortable, I'm sure that's happened for you as well. And just, it's hard as a provider or as somebody who knows that person personally, obviously. Do you have any advice for that, or do you want to share anything about that?
Yeah, I think it's going to be a real personal process depending on who you are and what your, cultural and faith and all that kind of experiences are. And it's terrible. And it's something where, remembering our own protective factors and remembering that we're not immune to this. Like our mental health, nurses have higher rates of, PTSD. Nurses have high rates of suicide compared to the general population. And watching our own selves, when something like that happens, and we need to take care of our mental health needs. And for many folks, that's going to be starting with our team. Like if it were a patient on a unit where we worked, then, hopefully there'd be something like a debrief, or sometimes they bring in the employee assistants like grief counselors or things like that. If you don't have those resources, or if it's somebody outside of that setting, find your people. And people that can handle the weight of this too. Sometimes that's not your friends. Sometimes that's your nurse friends. I'm a fan of everybody always being in counseling. I think that there's really no downside to having a therapist that you can they'll just listen to you and just and check in with you regularly. It's even just kind of like, we go see the dentist, even if we feel like our teeth are okay. It's having somebody that is in a professional role. I always think that's great when we can access that. And then, going back to our resiliency and taking a break if we need to, talking to our supervisor and saying, I can't handle this assignment right now. Or patient assignment or school assignment, heck, and then say, and take time to grieve. Sometimes people do a little service on their own, not, or they will, light a candle or say a prayer or write something down and just kind of have some sort of closure. And it's tough. And I think all of us in healthcare, if it's not suicide, we will experience the death of a patient that we, despite all of our efforts, didn't make it. And, a lot of those skills are going to, what's the word? They're going to work for any setting, but suicide does still have that added stigma in our society. And so kind of just, being aware of that and checking in on each other too. If we know that someone that we know has experienced a loss, check in on them. Even just saying, it's okay not to respond. I don't want to add to your mental load, but I'm here for you. If you want to talk, or I want to support you. Because this stuff is hard. It's no joke. It's tough.
Thank you so much. Do any of you guys that are present have any questions for Margaret? And if you do have a question, if you feel comfortable, go ahead and turn your video on. Or you don't have to.
Is it okay if I just talk like this?
That's okay.
Your name,
I can't see who's talking. I'm sorry.
Oh, it's Maddie.
Okay.
So I'm interested in becoming maybe a what is it called? Kind of what you are, like a DNP in psychiatry. What would you kind of recommend I do upon graduating?
Yeah, that's a great question. I would recommend getting some experience as a psychiatric nurse first. So working, I guess, anywhere you can. like in a hospital or outpatient or somewhere, you don't technically have to go to PMHNP school, but it is helpful both for admissions and then also just for kind of just that understanding. I know that because I worked as a psych nurse, and I guess I did, I worked in a lot of different settings, and and what I did know is that by the time I was in grad school, like I knew the meds front and back. I didn't know like the neuropathophysiciology part as well, or the psychopharmacology part as well, but I could tell you the list of meds in this category and this category, and kind of the dose, kind of is that dose a reasonable part of the range, and also had a lot of reps of doing, you know, therapeutic communication and even all the assessments that go on. So I would say if you can at all, you know, work in the field for a bit, and then, yeah, I mean, then apply. I would recommend, you know, researching schools and finding one that provides is known for a really good education. And then also now, maybe by the time you're in grad school, it'll be better. But right now it's very difficult to find preceptors. There's just an extreme shortage. And that's, you know, like the person that, you guys know preceptors, where, yeah, that you follow them around and then eventually hopefully have your own clients that they sign off on and they see as well. And so I would really recommend having an idea of who you would work with and make sure that person has the same idea, because that has been a big hindrance for folks in PMHNP programs now. And actually, I guess that goes for all nurse practitioner programs. I know FNPs also have that issue right now.
Thank you. That's super helpful.
Oh, and we should make a plug for APNA too.
Go for it. Student membership. Go for it.
Yeah, the American Psychiatric Nurses Association.
Actually, they're going to do the motivational interviewing free modules. So that's a great segue. Go ahead.
Perfect. I think they have a student rate too. I'm pretty sure.
$25.
Oh, great. Yeah, they've got lots of resources. They've got also this, like, they have mentor matches too. Like you can find a mentor there. And they've got, they have continuing education. They have transition to practice stuff. They also have a state chapter where you can get involved in the state. They love students. You have people you can talk to get involved.
I'm on the board of that, which sounds fancier than it really is. But there's also some scholarships, and I can help you with that. So student scholarships too. So it's a great way. You can, there's a journal, there's a conference, and you can even apply to be a scholar to get, did you do that? You did probably.
Yeah, it's in grad school, yeah.
Yeah, so you can get a scholarship to attend the conference.
Yeah, it's great networking.
Any other questions? We just have a couple more minutes left. They have an exam on Monday on therapeutic communication and meds and you know, the neurobio part of it.
Oh yeah.
So any awesome pointers you have?
Just the one. Yeah, I thought when I took therapeutic communication as an undergrad, this is before I even knew I wanted to go into mental health, I was thinking like, well, isn't this nice? I'm never going to use this. Or like, it just felt really fluffy. Therapeutic communication is like the most important thing. Like like every setting that you go in, when I see nurses who really don't have that honed in, it's bad news. Like, just, you know, if folks get escalated, it's really hard to de-escalate. And I notice it everywhere I go, you know, even again out in the community. If you can use therapeutic communication, it's so helpful for everything. So I would take it seriously. I'm sure you all are taking everything very seriously. But it's another one of those things that you can't run away from. Even if a psych is like last on your list, therapeutic communication is still going to be there.
Well, the cheesy line is like every nurse is a psych nurse. So.
Yes. It's true. You can't escape. Kind of that way with, you know, all the folks that say, oh, I don't want to work gero. And then you're well, unless you work with adolescents, but other than that, you're a psych nurse and you're a gero nurse. And so as well learn it now.
Any other questions? Can we say a big thank you to Margaret? Hopefully this was helpful for you guys. I know it's it's just a hard thing. Like that's why that's why I wanted to spend this time. It's super important, but it's also really hard. And I think the tendency is not to ask because we feel like we're not ready to. But I love how you said, you know, you don't have to do all these things, but you have to ask that first question and then connect with services.
Exactly.
So thank you, Margaret.
Well, and I will give Professor Alexander she has my contact info, but feel free to pass that on if there are folks who are, like I said, interested in mental health nursing. I've done a fair amount of mentoring too, and I enjoy working with students. So feel free to get in touch with me as well.
You're getting lots of thank yous. I'll forward you the comments. If there's one more last minute question, then we still have a couple minutes. Otherwise, thank you guys. After Margaret's done in a couple minutes, I will stay on if you have questions for the exam.
Cool. Well, I will get out before I have to do exam stuff. So
no,
thank you
Any other questions?
having me. It was a pleasure.
Thank you so much.
Take care.
Okay. So if you guys have questions, feel free to ask me. Otherwise, I won't take it personally. People are leaving me. I guess that means it's really easy material. Nothing? Oh, I'm sorry. Yeah, it's in Salem. I'm sorry if it was loud. I tried to mute myself. Yeah, I'm at Broadway Coffee House in Salem. Kombucha. Okay. You can talk too if you guys want. We're going to have to distinguish between tangential thinking and circumstantial thinking. I will try to make it, because I really am not trying to trip you guys up, but let's just talk briefly, because there is a big difference. Can anybody, you learn more when you answer things. So can anybody either type in or say the big difference between the two?
Tangential thinking, you never.
Oh, I'm sorry, I can't quite hear. Go ahead.
Tangential thinking, you never quite really get to the point.
Exactly.
Circumstantial, you do.
Yeah. So the biggest thing, I don't mean to oversimplify it, but like, do they answer the question or not? Because there's only two of the types from all the types I talked about where you actually get an answer to the question, which is circumstantial and the best, the easiest, logical. So logical and circumstantial, you actually answer the question. And then tangential is where you start to and you just take a left turn. So it still follows a train of thought, but it doesn't answer or stay on the topic. And I think we all have either ourselves or a friend that does that, you know. And then, so tangential still kind of making sense. And then loose associations are when there's these like weak threads in between. Does that make sense? I feel like I'm talking. Yes, thank you. Okay. I feel like I'm kind of talking to myself, but I hope not. I am talking to myself. People in this coffee shop are probably worried about me, but that's okay. Another thing that people asked about, and I tried to say this, but I want to make sure that I don't make you extra stressed for an unnecessary reason. That mental status exam, there are categories that are not in your book and that are very, very specific. I am not going to ask something that's not in your book. And I'm looking at the big picture stuff. So like, think about mood and affect. And really, just in general, like mood is either euphoric, is like really, really high and happy. And we all have that. We all have the range of moods. So if you're have an elevated or really happy mood, if you're, you know, like medium, which is like, you know, the euthymic, or dysthymic or sad. So knowing that, and that is, you have to ask somebody. You can't decide for them. So you ask them what their mood is, and you kind of look at their words. And then affect is their facial expression, the way that they're expressing themselves. And the big thing about it, especially to tie in therapeutic communication, because I will tie things together. That's why the questions are, it's hard to say exactly which chapter, because as we build things together, the questions are going to have a little bit of both. So if somebody has a really euphoric, happy attitude, affect, or I'm not making sense, I'm sorry. If somebody has like, their facial expression is like really happy and they look like they're smiling and they're, like, I'm really happy. And then the words that they're saying are really sad. And like the one that I showed you where the lady's talking about her dog dying, that is where therapeutic communication comes in. And I don't mean to like drag this out of you guys. If somebody wants to type in a statement they would say for that, or at least try to think about it, is how do you address that? How do you figure out what's really going on? And it's incongruent. That's the big word, right? So if the mood and the affect don't match, don't make assumptions that you know exactly what's going on, because you can't. You have to check in with the person and you have to ask some more questions. And then also the way you say it is super important. I feel really bad, and Sam, it sounds like I've terrified you to say the W word, to say why. But there are ways to ask things. It's just that you're asking why in a more gentle way. And I love how Margaret kind of talked about that with even the risk assessment. But still asking those questions, like, or you look like you're really sad, like your facial expression seems like you're angry or sad. Like I had somebody, with a mask on, I might be just like really serious, like, oh, this is a really good point. But with my mask on, I look like I'm mad, but I'm really just like deep in thought. And so you have to check in. You have to be like, it looks from your facial expression like you might be angry. You might be really thinking about something. Is something going on that's more than what you're saying? And maybe they're like, no. And so you have to put it all together. Hopefully that helps a little bit. I don't want to babble too much. Does that make sense? Okay. Thank you, Maddie. It'd be really funny if nobody was actually here, like you just didn't want to be rude and you walked away from your computer and I'm literally talking to myself. But that'd be okay. I don't want to keep you too long if you have more questions. One thing that somebody asked, I think I addressed it on hopefully you had a chance to watch the end at least of the lecture from Monday, from the client's response to illness. I addressed your comments from your exit tickets. So I spent quite a bit of time talking about some specific questions. And I wrote out some stuff too. Like I stated the meds that you need to know. And it's really not a huge list because it's more about the classes. I even gave you suffixes for like a shorthand because you need to know. Like if you see that somebody has a positive suicide risk assessment and they're on a medicine that ends in triptyline, that's a tricyclic. Like I don't want you to be like, I don't know. Seems like they're probably okay. Like I want you to be able to look at their med list and look at what's going on with them and be able to have that warning sign. That's really what I'm trying to do. Because it's important. Like I said, the tricyclics are one of the most lethal drugs. Like if somebody really has a plan and they have a couple weeks worth of that medicine, then they can end their life. Die by suicide. I'm trying to think of the best way to say it. Hopefully that made sense when we talked about that too. Anyway, one of the questions that people said was, how much do we really need to know about neurotransmitters? And that diagram that I used is really what I want you to know. And I didn't add, there's some really, really complicated stuff. Like we could probably spend an entire semester about a synapse. I mean, I'm not going to make you, but we probably could. So all the parts that are in that, because it's a pretty simplified diagram, you've got, the synaptic vesicles, and you've got the neurotransmitters and the receptors, and then the enzyme that degrades it. You need to be able to talk through that process. And I think a really good way to do that is to practice, because you need to be able to explain medications to patients. So I think if you can explain it in plain English to a patient about what's going on and why their medicine is important, that might help with compliance. And it might help with them to really, because SSRIs can take 4 to 6 weeks before they really start working. And so if you explain, this is how this is going to help you, and it's going to take some time for it to work, that might be a difference that actually helps them to keep taking it and to keep giving it a try. So I can't stress enough how much education matters. So know the neurotransmitters, know the big functions of what they do, and think about how that figures into the side effects and all that stuff. Okay. I know this was kind of an unexpected thing. I hope this is helpful. I hope you enjoyed learning from Margaret. I will stay on here. I won't take it personally if you leave, but I'll stay on here a couple more minutes before I stop recording because I'm going to share this. And then in the message I said, if you want to stick around and chat about anything not being recorded, then I'm here for you too, because we only see you guys on Mondays, and you have so many classes on Mondays that I just realized that it's hard to get time to check in even with each other. So I just wanted to at least offer that space for you. Any other questions? So I don't know if you guys saw chat, but Maddie said, stay safe, everyone, praying for you all. That's very sweet. If you guys can pray for Kathy as well. She was evacuated. And so this is a hard time for so many people. So, you don't need to email her or anything. She's plenty busy, but just keep everybody in their prayers, okay? Thank you, Caitlin. Thank you, CJ. I won't take it personally if you leave. It's all good.